So we'll talk about osteoporosis today. Osteoporosis. So mainly I'll be talking about pathophysiology, and we'll try to understand the treatment strategies for osteoporosis and try to derive them from the pathophysiology. So before everything, the definition goes like this: key osteoporosis is the decreased strength of bone, which increases the risk of fractures. Okay. So how exactly there is a decrease in the strength of bone, we'll discuss that. So before that, I just want to explain a simple concept, that is a bone modeling and bone remodeling. For these processes, bone modeling is when there is an osteoblastic deposition which is not followed by the osteoclastic resorption. Okay, so classic example is the oppositional ossification of long bones to increase the transverse diameter of the long bone. But a key concept pertaining to the pathophysiology of osteoporosis is something called remodeling. So what happens is there is an osteoclastic resorption and an osteoblastic deposition. This coupled process is called as remodeling. Okay, so in a normal person, there is an absolute equilibrium with these two processes, so that there is no net loss of bone, But in osteoporosis, there is an osteoclastic resorption which is way more than the osteoblastic deposition. So there is a net loss of trabeculae or bone per se. Okay, so before that, I just want to tell how exactly the osteoclastic resorption is carried out, how exactly it is done. So before that, I just want to say a few concept on mechanostat. So this concept is given by Harold Frost. Like a hemostasis or a hemostatic mechanism, hemostasis, how the platelets and other coagulative factors, orchestrate in keeping a stringent check on the bleeding tendencies and bleeding and clotting process. Likewise, bone also has a very important check to address two things. One is a loading or a mechanical thing which is which it has to withstand, and the second thing is bone is the main reservoir for calcium, so it has to maintain the physiologic balance of blood calcium to support the various physiological functions. So how exactly it does is, When if you take a femur or a hip joint, you know, the amount of load transmitting to the femur is so much that if it gets unchecked and gets transmitted all the way till the talus, probably talus will break off, you know. So you know, the bone has to have a mechanism to dissipate that energy, you know, or the load, so that you know it is uniformly, you know, dissipated and there is no such adverse things. So the mechanism, you know, adapted by the bone is whenever there is a loading, so there is a formation of diffuse microfractures which will dissipate the energy, you know. Yeah. So these small diffuse cracks, you know, they dissipate the energy, but they need to be repaired timely, otherwise it cannot take the next load, because the fractured bone cannot fracture again. You know, that part which is fractured cannot fracture again unless the fracture is healed and ready to take the next amount of load. So it has to be, you know, repaired. So then comes the remodeling, then comes the concept of remodeling, which remodels or repairs these microfractures. And the process which I am talking is a type of remodeling that is called as targeted remodeling. And to carry out how this physiological balance of blood calcium is maintained is you know, through various radioisotope scans and other, you know, investigations. It is found that a total of 18%, around 18% of total skeletal calcium is resolved and deposited each year, you know. So there is a constant resorption and deposition, and you know, a very balanced you know, blood calcium levels. So this very important mechanism again, which involves process of remodeling, which happens in generally all over the body, in most of the skeletons. So it is called as stochastic remodeling. Okay, so just keep this concept, we'll get back to it. So now I will explain how exactly the osteoclastic resorption occurs. So whenever there is a need, whenever there is a stimulus for the osteoclastic resorption, it first sensed by the osteocytes and osteoblast. And you must be knowing there are no parathyroid hormone receptors on osteoclast. Okay, I just want to tell this because the whatever osteoclastic mechanism, it has to be triggered by either an osteocyte or osteoblast or some kind of a cytokines or some pharmacological you know, things, but it directly cannot be, you know, activated by PTH or, you know, other key mechanisms. Okay, so first it is sensed by osteocyte and osteoblast, and they release something called as rank ligand. No, it is a receptor activator of nuclear factor kappa B ligand. Okay, these are a family of tumor necrosis factors, you know, very keen, very key role in the activation of osteoclast. So when these rank ligands are released, so the osteoclast has a molecule which is called rank, which gets attached with these ligands, and this will proceed to a lot of cascades of intracellular and some protein synthesis mechanisms, which ultimately activates the osteoclasts, and in fact these activated osteoclast and the this rank and rank ligand fusion product will also puts more and more of monocyte macrophage lineages into formation of pro-osteoclasts and osteoclasts. Okay, and through various intracellular and protein folding mechanisms, ultimately what happens is there is a raw surface with an exposed bone matrix. So some of the bone matrix proteins like osteopontin are on the surface now. The alpha V beta 3 integrin part of osteopontin attaches to the osteoclast, and once this process, the rank and rank ligand has started many of the cascades, so they will synthesize a lot of resorption enzymes and molecules required for the matrix resorption, and they also signal some cytoskeletal biomechanics to change into a ruffled edges so that it increases the surface area for the resorption. So the carbonic anhydrase isoenzyme 2 will form protons, and there are chlorides. These two, the proton through the proton pump ATPase and chloride through the chloride channel, they come into the something called as Howship's lacunae, where the resorption per se is happening. So they come into this and they create an acidic environment there, and this acidic environment is important for the activation of many enzymes, many proteases, and one among them is called cathepsin K. Okay, and of course whenever a body has a kind of mechanism which starts, of course it has a mechanism to stop this process also. So that mechanism is a molecule which is called osteoprotogerin. This is in fact a humoral decoy of rank ligand, which upon fusion it destroys the rank ligand, so the associated cascade of pathway shuts. Okay, and another important mechanism to be aware of is the WNT pathway. Okay, the wingless integrin pathway, will not go in detail about it. What exactly happens is this pathway gets activated whenever there is a mechanical loading or some cytokines or other things, and they inhibit the rank ligand synthesis, and they they allow osteoblastic deposition. This is kind of an explanation, biochemical explanation for the Wolff's law, that is, the bone remodels its micro and macro architecture and its form to cope up with the mechanical loads. Okay, so this is an important mechanism, and whenever there is a mechanism, there should be a counter mechanism to stop it, and that molecule which inhibits the WNT signaling pathway is called sclerostin. Sclerostin, cathepsin, rank ligand, osteoprotogerin, WNT and rank ligand pathways. Yeah, I hope you're with me. Okay, so this is how exactly the process of the resorption takes place. Okay, so so whenever before I go on to the treatment strategies, I just want to say there is a pathway called HMG CoA reductase synthesis. So this pathway is very important for the differentiation and the activation of osteoclast, which ultimately does its job, that is resorption. So there are some intermediary how exactly it does is there are some intermediary products which are very important for some changes. We'll discuss that. So what exactly happens is there is an enzyme called farnesyl diphosphate synthase. Okay, this will yield two products. One is farnesol and other is gernyl, and what exactly these two molecules does is they aid in transport of some proteins molecules till the cell membrane, and they attaches them to the cell membrane, and this process is called as prenylation. Okay, this is a very important, and not only the proteins transporting to the cell membrane, it also affects the cytoskeleton mechanics. One among them is formation of ruffled membrane to get itself attached to the matrix proteins, without which this cannot get attached and ultimately land up with apoptosis, because the activated osteoclast has to be attached. Otherwise, body thinks the need for the resorption is over, the surface which was exposed is no more, then there is no need for the osteoclast activation, and it ultimately leads to the apoptosis. So why I explained this is because this pathway can also be utilized in forming some treatment strategies. Like if you stop this enzyme, there is no formation of these intermediary products, and there is no prenylation, and there is no cytoskeleton biomechanical changes, and there are no ranks the rank molecules coming onto the cell membrane. And this exactly I am talking about the mechanism of action of bisphosphonates. Bisphosphonates. Because this enzyme requires pyrophosphate as a kind of a coenzyme or an activator. So the bisphosphonates are like of analogs for pyrophosphate, and they will displace this molecule and they will inactivate the enzyme, that is FPPS, farnesyl diphosphate synthase, and the rest of the thing fall in place. Okay, so in the treatment we'll talk about the treatment. Of course, the treatment starts with attending the risk factors. If a patient is on some steroids or some other medications, or uncontrolled diabetes, or a inflammatory disease, that have to be taken care. Patient should be given a nutritional supplementations like calcium, vitamin D, which is very important. Patient should be encouraged to do exercises which will give some stimulus to the osteoblasts, and that will increase the bone mass. Okay, so the per se pharmacological treatment is divided as an anti-resorptive medications and anabolic agents. Okay, so in anti-resorptive we are mainly we concentrate on the osteoclast inactivations, so that the resorption will not occur. Okay, so in anabolic agents we increase osteoblastic deposition to cope up with the osteoclastic resorption, so that the net loss is not there. Okay, so in anti-resorptive, the one among them is the hormone replacement therapy for a post-menopausal woman, because estradiol is a potent inhibitor of osteoclast. So you can use estrogen derivatives or progestins, or a selective estrogen receptor molecules. Okay, so the second group of treatment agent, the pharmacological agents, are called bisphosphonates. What these does is, as I already explained, they are the analogs of pyrophosphate. They inhibit, they inactivate FPPS enzyme, so there are no formation of intermediary products, so there is no prenylation, so there is no ruffle formation, there is no signaling molecules coming onto the surface, and ultimately that will lead to the osteoclast inactivation and an apoptosis of the osteoclast. Okay, and third mechanism is by the denosumab. This is a humanized